Hi, good afternoon, everyone. Thanks for joining us in this beautiful day. If we can switch to the slides, I'm going to start with a couple of slides. So my goal actually is to talk about brain metastases and what's the role of SRS treatment. So I'm going to start by just kind of walking you through a few of our cases that we would typically see in our department. The goal is actually to kind of walk you through three very different cases and three very different treatments. So I'm going to start by, just in terms of advancing the slides, I'm sorry. Okay. So I'm really going to start about the why and when we would use SRS treatment, and really the second part of the talk is the how. So the first thing is the case that you all drew on. So this was the 69-year-old. He had a remote history of an ocular melanoma. He was treated with brachytherapy, plaques, and really was doing well, had no evidence of any disease, and presented to the ER. And so the patient was actually very symptomatic. They had gait and speech abnormalities, and this was the MRI that was shown. So you can see that there is a large enhancing mass in the cerebellar vermis, and a second lesion also, I think, is seen with vasogenic edema and mass effect. So treatment options, what did we consider or do? So actually the patient was seen in the ER, was seen by radiation oncology as well as surgery. The patient was very symptomatic, and despite even being on steroids, the patient did not improve, and so he went to surgery. Okay, so he got resected, and we discussed with the surgeon, and underwent a craniotomy and had a gross total resection. So even given the size and location, surgeon felt that he was able to really kind of take it all in toto, and did a post-op MRI about 48 hours afterwards, and this is the scan that you're seeing, and really felt confident that he had a gross total resection, thought that this was really just the Surgigel that he placed in the cavity, and wanted us to discuss possible treatment options. So what could we talk about to the patient? So in actual fact, this was a scan about 48 hours. So we decided to bring the patient back in about 4 weeks, so 4 weeks from surgery. So we actually had a stealth MRI. So we at our institution have a Gamma knife. And so we did a frameless MR. So the patient had a stealth MR in preparation for a Gamma knife. And the cavity indeed did collapse, and was, this is the case that you drew. And so, again, the collapse of that large cavity, as well as kind of trying to figure out the extent of the margins, surface margins to cover. And so at that time, given the volume, we actually proceeded with Gamma knife. Now, sometimes, in some cases, we have cavities that do not collapse, and the volume is too large. It's over 4 centimeters. And so because they may be coming from a distance, we actually have use the same MRI, and actually we'll schedule them for a mask simulation. So if they can't have a framed treatment, they will go on to a fractionated frameless treatment. So I'll show you another case. So in this case, the patient actually went on to Gamma knife. The volume was about 5 cc, and so we gave 16 gray to the 50%. And we actually had a conformality index that was a little bit wider because of a little bit of the uncertainty. So it was 1.81. So this patient actually had a systemic workup and really just had some lung and mediastinal, very limited disease. And so the patient actually just received nivolumab for multiple cycles for over a year. And he's been on follow-up scans, had no evidence of any recurrence, and his systemic disease is well controlled. So I'm using this case to really illustrate that many of the patients that you'll see now will have a resection. And the question is what to do with them. What should we do? And I'm just going to talk a little bit about the reason why I picked this case was really to prove the point that it really is a kind of multidisciplinary approach, that we really need to work in cooperation because these cases aren't very straightforward or easy. And you can see, we'll go through the case, that there's a lot of variability in how we define that surgical cavity, how we define that extent, and plan the treatment. So this is a paper that was published. This is a case of a melanoma that had a large superficial lesion that was noted in the temporal lobe and underwent radiosurgery, was given 15 gray to the 80% line, and 7 months later developed an anterior recurrence. And so the purpose of this paper was really to illustrate that in their hands, patients who were followed for over a year. So by 1 year, their rate of failure was about 44%. And most of them were really anterior. So this kind of superficial duropele contamination by resection, this kind of LMD relapse that can happen. And so that not all surgical cases are good cases for postoperative Gamma Knife. And so that's why we're here today, just to kind of discuss some of these nuances, because it can be very difficult to define the collapse of the cavity, what extent of superficial surfaces you may need to radiate, and that risk of both recurrence, so if you're not covering sufficiently, that patient will recur, and also in terms if we treat too much margin, like some of the, I'll just show you the example of the case that we did today, by treating too large a volume, the risk of radiation necrosis. So in their hands, they had about a rate of 25% risk of radiation necrosis. So again, the volume that you're radiating, the dose, all of that will impact that balance between the toxicity and local control. So this really illustrating the point of the difficulty in postoperative defining target volumes. So I'm just going to show you data of the randomized phase 3 trial that really tried to compare focal treatment with radiosurgery versus whole brain radiation in these resected brain mets. So this is data that Paul Brown, that would be available, published shortly in Lancet Oncology. It was presented at last year's ASTRO session. So it's 200 patients. They were randomized to radiosurgery, and I'll show you the dose and fractionation. These patients were mainly lung cancer patients, and they were mainly solitary lesions, just kind of similar to the case I showed, one lesion. And the whole brain dose was 37.5 gray, and this is the radiosurgery dose. So again, another point just to kind of bring up in terms of what we're doing these days, in terms of dosing, in terms of radiosurgery dosing. So in terms of volume, so that it turns out that it's not, we've always worried about the number of lesions, but actually it's also the volume has a very important predictor in terms of outcome, but in terms of dosing. So in this particular trial, the volume dictates the dose, not the diameter. And so you can see that range in the maximum dose given at 20 gray. Because of that 2 millimeter margin, the work that Scott has done showing that in a post-resection cavity, that there is a little bit more uncertainty, so having a higher conformality index, especially for cases like this, probably has a better local control. So that's data that Scott has published. So the results, again, the primary endpoint of this particular study was neurocognitive and quality of life. And certainly as we expect, you know, the whole brain is going to do worse, and that cognitive decline persists. So I think there are multiple studies that Paul Brown has now shown that at 6 months, those patients who have that cognitive decline, it persists. It's not a temporary fatigue. It does kind of continue. But I wanted really to point out some of the when you're treating with SRS, well, what are the risks? What are the outcomes? So in this particular study, the survival was the same. So everybody did exactly the same. The median survival is about 11 months. But I really wanted to point out two things. So one is the surgical bed control. And most of the data that has been shown preliminary before this trial was it was just equivalent. It was exactly the same. But I think that's what's really key is to show you the difference between the two curves. It really has to do with patient selection. It's the person that you see in front of you. So the guy that we contoured on really had not very much systemic disease, and he had treatment with a systemic therapy that would really give them a long outcome. And in this particular case, again, you have to really follow these patients because even in their tumor bed, that risk of recurrence is going to be much higher by treating focally. So like that 7 month that you need to follow these patients, they'll continue to fail. So typically at 6 months, if the outcome is only 6 months, then there's really no difference. They'll have the same local control. But there is a difference in terms of the whole brain. And the second point is really that overall brain control, as we know. If you're going to treat with focal radiosurgery and not whole brain, they're going to continue to fail. So you have to image them and see them in clinic every 3 months, or you're going to miss that recurrence and they're going to be symptomatic and they're going to show up in the ER. So the really take-home message is that it is much worse, so they have to be followed. So the conclusions of this study, again, we'll have to kind of figure out what the best approach, but you can really see in this curve between observation, radiosurgery, and whole brain, there's a real conflict. So with improved local control, we also see increased toxicity. And so it's really a careful patient balance to pick the right treatment for the right patient. And this is not that straightforward, and that's why we really do it as a tumor board setting in a multidisciplinary approach, taking into account age, performance status, the extent of systemic disease, the extent of their systemic options, and it's not just a yes-no. And really, it is an equivalent survival, but they have better preservation of cognitive function, quality of life, and less toxicity. So it's more the kind of outcomes that the patient will recognize more than survival. Okay, so really just in terms of conclusions, in terms of this whole vignette, I really wanted to suggest that, with upfront whole brain radiation, you're going to get more cognitive function, quality of life. That's the why. And certainly if you're going to treat focally, the key thing is that the follow-up, it's not just the drawing the contours, but we have to follow these patients because they're going to be at risk of failure. And really that it's perhaps the whole brain does play a role. If we don't do whole brain, then perhaps, again, we're proposing a SWOG trial to look at other options to help with improved intracranial control, because that's still an option, an important part of how patients do in terms of cognitively. So if we can perhaps give systemic treatments or other things, what we call chemoprevention, that may help improve that control, that's really where we're hoping the field is going. So I'm hoping this is interactive and there can be some questions. I just wanted to showcase very quickly 2 different other scenarios that you might see in your clinic. And this is a case of a 74-year-old that we saw. Again, completely otherwise, had a remote history of bladder cancer, had surgery, no other therapies, and came in with a 2-week history of severe neck pain. And presented to the ER with, just all of a sudden he fell, he couldn't walk, he couldn't talk, and he had dysmetria. And this was the scan. So again, he has hydrocephalus. There's quite considerable hydrocephalus that you can see. And he actually had 2 lesions. And we were consulted as an inpatient to see what we would do for this patient. And actually, the patient was started on steroids by the time we saw him. And by the time neurosurgery and I both saw him together, he was completely well. So 100%. He was now walking, talking. His neck pain was completely gone. And you can see, I just wanted to showcase a different case. So if I had asked you to draw this target, I think everyone would have drawn the same target. I think we would have been really pretty straightforward in drawing that. And that just illustrates, so in this particular case, we actually, because of those risks of LMD and radiation necrosis, we actually, this is something that we're doing more often in our clinic. We gave preoperative radiosurgery. So he was in-house. We treated that large lesion to 16 gray. The volume was fairly similar to the case that you drew. It was about less than 5 cc. And again, the goal, the neurosurgeon is going to operate. He operated him 5 days later. So he had OR time. The patient was watched. Patient did not require a shunt. He did very well. And the patient actually had no other disease. The patient had a PET scan and had no disease elsewhere that could provide tissue. And what I'm showing are 2 curves, and so I know it's hard to see, but really this is pre-op and post-op. So the risk of LMD and the risk of symptomatic radiation necrosis are different between the pre-op and the post-op, and Scott actually is running a trial is to randomize between pre and post. So the case that we saw in patients who are asymptomatic, they could be randomized to pre or post, and we could see what outcomes or how different it would be in terms of outcome both for leptomeningeal disease and radiation necrosis. So I'm just going to very, very, very briefly, just for your SAM questions, just kind of point out that imaging changes post-radiosurgery can be very tricky, especially locally where you treated with radiosurgery. So many times they say, oh, it progressed. And what you want to do is we do this frequently, is we co-register our treatment plan to the MR. So they come back for follow-up and we say, look, we have to register your MR to the treatment plan. And many times that 12 gray line fits exactly with the imaging changes that we see. So this is really just an imaging change and the patient needs to be followed. So over time that the imaging change will resolve. So again, 3 months. So typically seen around 3 months. And if we do see radiation necrosis, this is a treatment that we are giving to our patients. So patients may get bevacizumab. So I highlight this again in terms of our SAM question. A treatment for radiation necrosis is bevacizumab. But there's a randomized trial. So again, Victor Levin ran the smallest randomized positive trial, 14 patients, showing benefit with bevacizumab, 7 out of 7, and 0 out of 7 placebo. But it was a very small trial. So Caroline Chung having a randomized study of Bev versus placebo exactly for patients with radiosurgery who develop radiation necrosis, and we are enrolling patients in that study. Okay, back to our case. So this last case. So the purpose of this case is really to showcase, again, the role of other treatment options. So this is a 54-year-old with HER2-positive breast cancer. And she had very good systemic control. She was doing fine. She was completely well. But she actually presented to the ER acutely with symptoms of headaches, altered mental status changes, and left facial droop. Of course, an MR was done and really showed this large lesion. There was actually 2 lesions that were noted, and the patient was symptomatic, did not get better on admission, and the surgeon removed the temporal lesion. And the resection he had actually looked really good, looked like he had a very good resection. But when we spoke to him, he was very concerned of his resection because it really breached the ventricle. And he said, look, this patient really has a very high risk of LMD. I don't feel comfortable giving any local therapy. So we put the patient on a study. So the patient was therefore enrolled on Dr. Kim's study, so this is still open, RTOG 1119, and the patient was randomized to whole brain radiation, 37.5 grain, 15 fractions with concurrent lapatinib. And actually showcasing one thing, so she got whole brain radiation. She did very well in the local site, no evidence of any recurrence or any risk of LMD, but the cingulate gyrus lesion that she had actually grew. So on follow-up, we followed this and we were certain that this was tumor progression. And so this was given radiosurgery, 20 gray in a single fraction. So again, that key of follow-up. If you don't follow these patients, you're going to miss that they're going to have recurrences or progression that require treatment in a timely fashion. So that was radiated. The patient was moved on to another systemic agent because of, certainly with HER2 positive, she had other alternative options and doing very, very well. So again, in many of these cases that we're showing you, the CNS control is so important. What you choose for the CNS will dictate how they do. It's not just their systemic disease. And I just highlighted these 3 cases for those reasons. And really kind of just a take-home message, again, it's really about a multidisciplinary approach. And again, I showcased some of the SAMS questions that you'll be seeing. And I really wanted to kind of switch over to the case, but really kind of to talk about some of the details, you know, the how. So how do we, what are the details in terms of planning? So in our particular case, again, we have multiple approaches. So we do this Encompass mask. If they're doing fractionated treatment, we actually mostly do frame-based. With brain mets, we're actually moving more to the mask treatments because many of these patients will be treated more than once. So we think that even with single fraction, that we are treating more of these patients with mask-based than frame-based. In our institution, our neurosurgeons still feel very, very strongly about doing MR and CT. So for all the cases, we do a CT scan as well as MRI, and that's one of the things that we always go over is the registration or the fiducial registration to make sure that at the level of the target, so we don't really care elsewhere, but really at the level of where we're treating, that registration is good. And really a key piece to help you, certainly with some of the volumes that we saw, again, is the imaging. So we actually do have a dedicated Gamma Knife protocol. Again, I didn't highlight it for this particular, but in terms of sometimes using MP-RAGE or other things can be very helpful in delineating normal tissues, as well as getting T1 and post-GAD T1. Sometimes for certain situations we'll get a post-GAD T2, but that's our typical formula. So again, I think the key thing that I wanted to really mention about the how is really the safety aspect of this in terms of how can we do radiosurgery safely. We talked a lot about that with spine, with the brain, it's the same. So it's location, location, location. So the size of the lesion is going to dictate your risk of radiation necrosis, but also proximity to normal tissues. So we do look at V12, especially for single fractions, very, very carefully, because minimizing that, getting that conformality index to be good but not so good, those 2 aspects are very important. Brainstem doses, but really optic structures. So for our optic structures, again, in certain situations, we'll make sure that it's really much, much less than 8. Again, for other situations, again, kind of looking at a max of 10 gray. Again, these are mostly kind of point doses as opposed to giving the whole structure. Other kind of comments about some of the EDUCASE that you'll see. Again, really, people did very well on their brainstem contours. Again, typically midbrain and the the medulla and the midbrain, everyone it's fairly straightforward and easy. I would say that the pons, again, in terms of that lateral extension or even posterior extension, there's a little bit of variability that we saw, but otherwise, in terms of the normal tissue contours that we saw for brainstem, everyone did a fabulous job. Really, in terms of the optic chiasm, again, this is really a very key structure, just like the spinal cord. So in terms of sometimes, again, knowing that the structure is so small, and so sometimes, again, the thin cuts is going to help you. The coronal tends to be the sequence that really showcases it the best. Knowing that you're going to be kind of anterior and behind the anterior clinoid and above the sella turcica. Sometimes we see people draw kind of really way inferior, and so those are the kind of highlights for that. Certainly for the optic nerves, drawing from the posterior globe to connect to the chiasm, we usually get all these structures to connect. And certainly in terms of the location of where the optic nerve goes through the skull, through the optic canal, and using CT can sometimes be helpful. We usually say for the optic nerves, looking at a sagittal view as well to make sure that you drew the nerve and not the muscle, and those are the kind of some highlights. Dose, we talked a little bit about, but again, I just kind of, most of everyone knows the Ed Shaw data looking at measurement by diameter, but many of the trials, so I highlighted the lapatinib trial that's combining with another radiosensitizer, but really in terms of other trials, kind of using volume as the dosing as opposed to just looking at diameter and kind of coming away from that 24 gray. Unless it's really less than 1 centimeter. Very small lesions, we're kind of staying away from that higher dose. So those are the dose constraints. Sometimes, again, with hypofractionation, those are some kind of key aspects of things that, if we can switch over to the EDUCASE. So I really want to entertain questions. We had a lot of great questions for the spine. Are there questions from the audience? Yes? Yes. So I think that's, again, I didn't quite showcase that, and I certainly would be curious to say what Scott, we have a physicist that comes from Stanford, and we were talking about that actually in our Gamma Knife suite about number, and they were talking about treating up to 15. And I would say that in our institution, we really try to stick to the 1 to 3 based on Paul Brown's data, or even 1 to 4. And people are, quoting this Yamamoto data that beyond 4, 5 to 10 is very similar. So I'll say that I think that kind of we need to do those trials. Those trials are ongoing. They will compare it and do it in a prospective data. I think you have to be very cautious because you start to really do whole brain by doing that, and that low dose may really cause cognitive issues. So I want to bring up that point. And I really, again, in terms of treating a large number, really what are we, if that patient, if you scan them in 3 months and they have another 10, they're going to need whole brain anyway. So again, these nomograms that our colleagues at Wake Forest, being able to select patients that are more likely to have control with good systemic therapy. If they're not going to get control, you might as well give whole brain. In fact, some of these patients may not even need any treatment, right? I think the key thing that we all forget is that we are so fixated that we don't recognize about the patient. Some patients only have 2 months to, that the Quartz data of just doing best supportive care is just as good as whole brain. So the 20 gray and 5 fractions or other aspects are. I would say that it's more and more difficult, I think, these days. I'll say, so a 40-year-old just showed up in our department who had non-small cell lung cancer, had tiny, like 2-millimeter lesions, and was KPS of 100. And so, again, they had, 8 lesions. And so the struggle is if we gave whole brain, they couldn't go on clinical trial. They had to have a washout, and their systemic disease would progress. And so I think it's very difficult. It's not straightforward and easy, and you can point to someone and say it's not a reasonable thing. But I think it's just, again, the whole crux of this is just careful patient selection. It has to be careful because not all, 15 METs would benefit.
Yeah, similar to the heterogeneity in practice that we talked about in spine. There's obviously heterogeneity between radiosurgery and whole brain. You mentioned the Yamamoto data, so we do have prospective data for 1 to 10 for survival. You're right that we don't have cognitive outcomes on those patients, but you do have data up to 10 for radiosurgery alone with withholding whole brain until needed. There are trials,
Yeah, the Alliance is going to run a trial, yeah.
yeah. So we have prospective data to justify up to 10. We need better data, I agree with that. 10 patients, 10 small metastases in a young patient properly selected, we will not do whole brain on them.
So for our patients, again, it depends on the agent, right? So a lot of our patients are getting combined immunotherapy, and we have not much concerns for those. If they really are having something that's a systemic chemotherapy, then we try, if we can, for 2 weeks, 7 to 10 days. I don't know.
Yeah, there aren't a lot of data. TKIs or other systemic agents, we say 3 or 4 days. So if they stop on dead life cycle Thursday, Friday, we will treat them the following week. But the longer the better, but you have to factor in the delay in chemo.
In terms of giving it concurrently? In terms of concerns of giving it together, or? I've actually, usually we just have them continue, so we never stop for that reason. They need their systemic treatment, so it's that principle that whatever their systemic treatment is, that's holding at bay and working, and then we just work towards combining our chemo and radiation. And this aspect of immunotherapy and how to combine, especially for targeted treatment, in which order, it's, again, controversial. Instead, there are clinical trials being run to test those questions.
Yeah, there are, I believe it's Stephanie Weiss has a case series of patients on Bev at the time of radiosurgery where they had essentially almost a paradoxical reaction where it looks like it did radiosensitize. So Bev is good to treat necrosis, but there's at least some data that maybe it increases the risk. Those are just small cases, so I usually don't hold Bev if they're on it for radiosurgery.
Are there any other questions or interest of time? I'm just concerned. So this was the case that we talked about initially. This is the post-op cavity that was treated. I just wanted to showcase a little bit of that kind of variability that the audience in terms of drawing that cavity. And again, we talked a little bit about some of the downsides and risks in treating a larger volume. But I think most people actually, if you look at it, was actually very similar. The key things is really that what Kristen talked about, we put up our pre-op and our post-op, we look at the SAG, this ortho view, we make sure our SOUP and INF matches where the surgeon would like that and is concerned about, and then that width we look axially. So all of these things help us in defining what's surgical scar versus residual tumor. Having their input together is really key to these very difficult target volumes. This is kind of a showcase of why I wanted to show this. We can kind of quickly look at other critical structures, but actually I will have to admit the audience did fabulous on all the chiasm and normal optic structures, so kudos for the audience for that.
Well, you're bringing that up. One subtlety is you mentioned that you got a post-op MRI to just see if it's gross total resected or not. The other benefit of the post-op MR is that a few weeks later, when they come to you for radiosurgery, you may have a nice cavity with enhancement coming off of it. But if you look back on the immediate post-op, that's actually an area-restricted diffusion. So that's infarct that is now enhancing rather than tumor that is there. So that's the benefit of that. So if you have something that looks funny, it doesn't look like tumor, go back, look at the DWI, and it may actually be infarct.
Yep, so that is very key. When we talk about post-op, that's the scan we're talking about in terms of defining it. Are there any other questions? Thank you.